Good morning and welcome to the Talking with Dolores Elder Mental Health, Depression, and Suicide webinar. My name is Brandy Brooks, and aside from being the moderator this morning, I am a contract manager for the Massachusetts Department of Public Health's Suicide Prevention Program, the sponsors of this morning's webinar. Before I introduce our presenters, Dr. Kerry Morrison and Rebecca Kessler, I would like to go over a few housekeeping issues. First, to join today's webinar and participate fully, you need to dial 1-866-740-1260 and enter the passcode 624-5494. In addition, to view today's presentation and the video, you need to go to www.readytalk.com, and in the top left-hand corner, you will see where it says Join a Meeting, and you want to enter the passcode 624-5494. Again, that's 624-5494. Now, should anyone experience any technical difficulties with either the audio or video for this webinar, please dial 1-800-843-9166. Again, that's 1-800-843-9166, and a Ready Talk representative will be more than happy to help. Second, all telephone lines are muted except mine, Carrie's, and Rebecca's. So please use the chat function located in the lower left corner to type in any questions you may have. Carrie and Rebecca will do their very best to answer as many questions as possible as we go along and at the end of the webinar during the question and answer period. Now that I've gotten that out of the way, let me introduce our presenters this morning, Dr. Kerry Morrison and Rebecca Kessler. Dr. Kerry Morrison is a clinical psychologist who is the creator and lead trainer of the L.I.F.E training, which is Living for the Elderly, at the Center for Human Development. The L.I.F.E training was funded from a grant from the Massachusetts Department of Public Health. Dr. Morrison is the former coordinator of the Garrett Lee Smith Suicide Prevention Grant funded by SAMHSA at the University of Massachusetts Amherst. She is also a trainer of assessing and managing suicide risk for the Suicide Prevention Resource Center and a QPR trainer as well. In addition to providing consultation to many agencies and schools, Dr. Morrison has a private practice in Greenfield, Massachusetts, where she provides services to clients of all ages from 6 to 85 years old. Dr. Morrison's colleague and co-presenter this morning, Rebecca Kessler, is a co-trainer for the L.I.F.E training, Living is for the Elderly, and a coordinator of the Suicide Prevention Grant at CHD, Center for Human Development. Rebecca is also a crisis clinician for the Behavioral Health Network. She was the former community outreach coordinator at Hawthorne Services for 4 years before they merged with CHD. So without further ado, I will now turn it over to Carrie and Rebecca. Are you guys there?
Yes, we are.
Okay.
Well, this is Kerry Morrison speaking. Thank you very much, Brandy, and thank you everyone for joining us. I would like to go to this slide here and have you fill out which field you represent. It might help us get some more information about where you're coming from in order to tailor the training today. So if you could take a minute and click the appropriate box that represents your field of employment, that would be great. Okay. Okay, so it looks like most of the folks on the webinar today are mental health, public health, senior centers, social services, and something else not listed. Okay, so I think we're all set. So depression and suicide in elders is a major public health problem, and it affects many elders. The statistics that we have on elder suicide, we think, are actually very low due to the stigma of reporting a suicide and due to the fact that many medical examiners, even when they know that the death is caused by suicide because there's a note or indication from the family, will not actually report it to the authorities as a suicide because of the stigma and the shame that may be caused to families. So the number we have is about 5,000 suicides of those 65 or older every year in the U.S. happens about every 83 minutes. The highest group is white men over 85, and they're 6 times higher than any other segment in the population. Most individuals are in relatively good health. 80% have seen a provider within the month of their death, and 40%, excuse me, I'm skipping to the wrong slide, and 40% have seen a health care provider within a week of their death. About 10% have seen a health care provider, PCP, nurse practitioner, on the actual day of their death. One of the problems with treating elder depression and suicide is it's not easily recognized by healthcare practitioners, or they may avoid the conversation because they don't know what to ask, they don't know what to do, and they don't know the resources to refer an elder to who may be at risk of depression and suicide. Excuse me, the slides are skipping around a little bit. And that's also true of healthcare professionals and therapists, that they may not be trained to recognize the warning signs and for those elders who may be at risk. So a lot of it really needs more training. I know when I was in graduate school in the 90s, we got absolutely no training on suicide prevention. We actually learned mainly by the seat of our pants. When we were in our practicums or internships or actually our first job placements. So hopefully through this training you will get more of the skills on how to recognize an elder at risk and to know what questions to ask if you suspect that someone you work with may be potentially at risk for suicide. And Becky, I'm going to turn it over to you to describe the play.
Okay. So at the beginning you saw that it says Talking with Dolores. And so Talking with Dolores is a DVD that we have that actually originated as a play, and we got it taped by WGBY in Springfield. So we have it in DVD form. So you'll just be seeing clips of it throughout the training because obviously we can't show the entire movie. It's about 45 minutes long. So we just kind of picked the clips that would be most showing of depression and some signs of possible thinking of suicide for this character. So Talking with Dolores is a one-act play about life and death choices related to grief, loss, depression, and elder suicide. And the play and the DVD was possible by the Department of Public Health. It was written by D. O'Connor, and it was directed by Steve Henderson. And Steve Henderson is actually the main character, Mo. And Mo is an 85-year-old diner owner who lost his wife, Dolly, a number of years ago. And there's a couple other characters, too. Psy.D. Psy.D is Mo's next-door neighbor. She definitely, and I don't know if you're really going to pick this up with just the little clips that we show you, but she's definitely more interested in him than just his neighborly companionship. It looks like she has a crush on him, constantly trying to get him to go to do things with her. And then there's Matt, which is Mo's nephew, and he took over managing the diner since Mo retired.
Okay, so why watch Talking with Dolores? This is a really great training tool that you can use both with elders themselves and peers who may be at at risk for depression and maybe contemplating suicide, but it presents it as kind of an outside medium that audience can, talk about their concerns about talk about their concerns while looking at the play, so they don't have to talk necessarily about their own feelings. But it represents in artistic form a lot of the issues that various folks struggle with. And when this tool has been used in senior center and other aging communities, either as a DVD or a live performance, it has really generated a lot of conversation about risk factors, warning signs, stigma, questions to ask, and not so helpful questions to ask for elders who may be contemplating suicide. Mo's current situation. Mo is the main character, as Rebecca mentioned, in this play. He's an 85-year-old male, widowed, diner owner with no children, who lost his wife, Psy.D, a number of years ago. I believe that Psy.D passed away due to cancer. Mo seems to have lost any interest in life, any pleasure, seems to have recurrent thoughts of suicide, is giving away his possession, talking about ending his life, and maybe having trouble sleeping. He also has some health issues and doesn't appear to be sticking to his diet and health regimen. Clearly is still grieving the loss of his wife, Dolly, seems no reason to go on, and does not seem to be a very religious or spiritual person. Has had a previous suicide plan or suicide pact to go to a place in his area called Purgatory Chasm to be reunited for his wife. Although this isn't mentioned directly, we believe that this is a type of area that he would jump off in order to commit suicide. He is retired from the diner, so has no work situation to get him out of the house, and seems to be depressed. Becky, I'm going to turn it over to you.
Before you guys keep going, I've been asked if you could turn your volume up and or speak louder.
Okay, we'll try to do that.
Okay, I'm going to try. My volume's up to the max. But so some common events or life circumstances that increase the risk of suicide among, I just would say people in general, but specifically to this case, having persistent headaches, stomach aches, acute or chronic pain. Lots of times I see that being a crisis clinician too. A lot of people who are in chronic pain definitely can't deal with that and think about suicide. Any type of illness, especially having multiple illnesses or debilitating illnesses or life-threatening loss of employment or productive activities, like Carrie said. Mo is retired now, so he really doesn't have any reason to leave the house. Inability to live alone. This is probably the first time that Mo has ever lived alone because, back when he probably got married to Dolly, he probably just left his parents' house and moved in with her, and this is probably the first time he's ever really experiencing that. Obviously, death of a spouse, loved one, or even a pet. And loss of autonomy, independence, or mobility. We don't really know if he drives or anything, but a lot of times with elders, if they can't get out or if they lose their sight or hearing or things like that, that definitely causes it. Depression, obviously, number one reason why people think about suicide. Loss of role in the family or community. Physical, social, or emotional isolation. Financial losses or difficulties, substance abuse or dependence definitely increases the risk, especially the ability to act on it. Family member that has died by a suicide or past suicide attempt. Now that could be, we all know that suicides definitely run in the family, but even watching somebody like a mother or something having multiple suicide attempts throughout their life, or even their own past suicide attempts. We all know that people who have attempted once are more and more likely to attempt again. And major life transitions. It's not apparent in Mo's situation, but somebody who needs to move into like an assisted living or a nursing home might be starting to think about suicide. And other people also have they might think other people have lower expectations for them. So now we're going to actually see a movie clip. This is, I believe, when Mo is sitting on his couch talking to the picture of Dolly, his wife, and just talking about, missing her. So we are going to play that now.
Okay, I'm not sure how the volume was on your computers, but mine it was hard to hear, and some of the clips I think were stopping and starting, so I apologize for that. But the situation was Mo was talking to the picture of his deceased wife, Dolly. You can see on the coffee table there's a picture. And he's talking about, how his life has no meaning. He does not know what to do. And in that scene, you saw some of the warning signs that, he's kind of lost his life, lost his desire to go on. He's contemplating what the next step is for him. So that's a couple of things to think about. In the next clip, which I hope you can hear better, let's see. He is talking, the knock you heard on the door, hopefully in the last clip, is his neighbor Psy.D coming in. And I want you to notice if you see any particular warning signs in this clip. So hopefully that will run better. Okay, so I'm hoping the volume was a little bit better. If you couldn't quite figure out the scene, the neighbor Psy.D was coming in to try to encourage Mo to do more things, to get out of the house, basically to feel less depressed. When she noticed on the coffee table there is a beautiful piece of lace that his deceased wife Dolly had made, and she noticed that there's a stain in it, and makes a comment to Mo, and Mo says, "Oh, no, you can have it. It doesn't really mean anything to me." So I want you to, as you watch the next clip that Becky will set up, watch for other warning signs. As we talked about before, giving away possessions is certainly something that's a warning sign. But other depressive symptoms, feeling nervous, empty, worthless, tired, irritable, agitated, feeling like a burden to others, feeling hopeless, helpless, unable to cope, feeling trapped in their situation, like there's no way out. Also, preoccupation with death, statements about death, making both indirect and overt statements or threats about suicide, and lack of flexibility, adjusting to change, feeling like there's no joy or life isn't worth living anymore, and feeling that life has no meaning, and not taking care of oneself, following healthcare regimes or diet regimes, grooming, or taking medication. As well as any sort of changes to personality or mood, statements of hopelessness, lack of concern about personal safety, and increased risks, and not sleeping, either wanting to sleep the whole night and half the day, or not sleeping at all. Global insomnia in particular, people who don't get good sleep, can be a major precursor or risk factor to suicide. Also experiencing being slowed down, fatigue, low energy, increase in either alcohol or drugs or prescription drug use, social isolation or withdrawal, not wanting to go out, not wanting to do things, and putting one's affairs in order, changing wills, communicating that information to loved ones, saying goodbye to people, and prior to suicide attempts, as Becky had mentioned. So as you view the next clip, I want you to look for these warning signs. And we're going to go to the next clip.
So the next clip is Mo. He had just gotten a prescription filled from his doctor, and it could be Ambien, it could be some type of sleep medication. And we're kind of wondering why he got that prescription filled, since we're not sure if he was having trouble sleeping. But anyway, here is the clip, and like Carrie said, just look for the warning signs.
Sorry for the interruption, darling. That woman can go on. Where were we? Oh, yeah. Purgatory Chasm. No, I guess I won't be going up there tonight. So I had to figure another way to get back to you, darling. Can't go on this way. Maddie's all set with a diner, and everybody else I cared about's out of the picture. Except you. You're the whole picture now. I figured the best way for a tired old man would be to take some sleeping pills. Maybe in my dreams you can take my hand and lift me off the edge of that cliff. I picked up the prescription today. Doc says take no more than 2 a night. And I hear if I take the whole bottle, I'll just chuck them up. Trouble is, I don't know the exact dose. According to that Hemlock Society book, I might need to take about 20. So I'm figuring a few less might do it for an old fart with a bad heart. Figured we'd have some dessert first. Kind of a last meal for the prisoner. Picked up some of those cookies you love so much at Angelina's. Just 2. Guess I'll have to help you finish yours. Damn pharmacy. I told them not to use those senior-proof caps. Damn useless hands. 17. That should be enough. Damn timing. Who the hell could that be? I swear, Dolly, if I didn't know better, I think you were still trying to keep me from coming back to you. Who the hell is that?
It's me, Uncle Mo. Who else would it be this time of night? What are you up to, Uncle Mo? Hey, what's this stuff all over the floor?
Oh, damn pharmacy gave me a child-proof cap again. Do I look like a child to you? You think I still got babies running around the house? Yeah, man, get them picked up. Put them back in that container. But don't put that foolish cap back on.
What's with the sleeping pills, Unc? You been having trouble sleeping at night?
Just every now and then. Doc gave me a prescription so I can have them on hand if I need them.
Yeah, they're risky, though. You can get hooked, maybe even OD.
You know, at my age, I'm not too worried about becoming addicted. What's that going to cost me? A couple of dollars a month in copay? As for the other, if I want to go to sleep for good, that's nobody's business.
You've actually thought about it. Why the hell would you want to do a thing like that?
Why not might be a better question.
What are you talking about? You're as healthy as a horse. You got friends, you got family, the diner. A lot of folks would be happy to be in your shoes.
I'm not saying I'm checking out. I'm just saying, with just a few years left of nothing much to look forward to, why wouldn't I be in a hurry to get back to your Aunt Dolly? Anyway, I don't want to talk about this tonight. What'd you come here for anyway?
Oh, Joe Duggan came by, dropped off your...
Okay, so I don't know if you guys noticed any warning signs in the video, but there was also some protective factors that I think Matt, his nephew, had mentioned. But this is specific to Mo. He has a caring nephew, clearly. He's got friends. He's got a neighbor. He's got connection to the community through the diner. Even though he may not work there anymore, he definitely through the years has built up quite a reputation and knows people in the community. He is relatively healthy, so we think. He's starting to share his feelings and open up about his thoughts of death with his nephew, and there's no apparent substance use, and there's no known history of depression for him, past suicide attempts or deaths by suicide within the family. So
Becky, before you go on, I just want to say, in case people couldn't hear the sound of the clips, what you were seeing in that scene was that Mo had gone to the pharmacy and picked up some sleeping pills after getting a prescription from his doctor. And he was trying to open the bottle, but was struggling to do it and spilled half of the pills on the floor. His nephew, Matt, that now runs the diner that Mo had established, comes in and finds the pills all over the floor, and they have a conversation about why is he taking sleeping pills. And Mo, early on in that clip, had said that he'd done some research online with the Hemlock Society and various organizations that might give information about ending one's own life. And he figured out, due to his age and body weight, that he would probably need 17 sleeping pills in order to kill himself. So Matt collected the pills, put them in the bottle, and then Mo, I think prior, had put 17 pills in the pharmacy bag. So that was a clip you saw, in case you couldn't hear. And then Becky's going to continue now with strategies, how to approach someone to have a conversation about whether or not they're suicidal.
So you can tell that Matt, he's starting to open up to Matt, and Matt is starting to talk about it. So one thing that we should all do if someone is starting to talk about suicide is definitely acknowledge that they may want to take their own life. Even though we all know that's probably not the best answer, but it is an option, and people have been thinking about it. So don't completely rule it out, just acknowledge that, okay, that's a possibility. But then discuss the pros and cons along with the advantages of choosing life. Talk about the reasons to live. Like often if they're religious, play that up, because religious people, especially ones that believe in God, for instance, they believe in heaven and hell, and the belief is if you commit suicide, then you're going to go to hell. And if they're religious, they're going to think about that before they do anything. Reasons to live, such as what if they have grandchildren? What if they have another grandchild on the way? I mean, sometimes that enough is to get people to think, because often when people are depressed, they forget about all the good things in life. And then also help them generate some solutions to the current problem. Give them other ideas, because often people who are depressed and feel that suicide's their only way out just really can't see any other way. They have what they call tunnel vision, cognitive constriction. And you can also suggest to the person if it's not really going anywhere, maybe they need to talk to their pastor or spiritual advisor if they're religious. Maybe they can talk to a counselor or another mental health professional. I know often with elders, when I see them too and suggest that they start counseling or something, they're like, I don't need to go to a shrink. I'm not crazy. It's really kind of all in the language too. Usually counselor or social worker is acceptable. Take a medication for depression. Maybe they can go to their primary care doctor and talk about some type of medication, or maybe their primary care doctor can refer them to somebody. I know not all the time primary care doctors are comfortable with that kind of stuff, and they could also join a support group or a counseling group. Sometimes this is often offered, at the senior center or so.
Okay, so we're going to see another clip, and again, I hope the volume is audible here. If not, I will try to set it up as much as I can. This is kind of a continuation from the last scene with Mo and his nephew Matt talking about his sleeping problem and taking the medication, and what he's thinking in terms of ending his life, and just view the conversation. And we'll try to recap, but hopefully the volume will work on this one. So let's skip. Okay, I'm just going to recap because I think the volume initially was a little bit better, then it faded out again. So Matt had come in and found the pills all over the floor, collected them, and decided to throw them away. But now you see Mo with the bag, the pharmacy bag, and he has 17 sleeping pills in there, which he assumes is enough to kill himself. So you may want to think about Matt's response to Mo of, having a little bit of a conversation, but then flushing the rest of the medication, the sleeping pills, down the toilet. And when Matt made the comment about thanks for understanding about the diner, Matt had decided to sell the diner because it wasn't working economically for him, and he was in dread about telling Mo that he was going to do that because Mo was the one that established the diner. And I'm going to turn it back over to Becky about appropriate responses or helpful questions.
Okay, so things that you or Matt could have said, I'm sorry you're feeling poorly. Tell me more about how you're doing. How long have you felt this way? Do you think that life isn't worth living anymore, or would you be better off dead? Are you thinking about killing yourself? Now, that question alone, I think, is anxiety-provoking for a lot of people. We often call it the S question, and it can cause a lot of anxiety, even for people that do it every day. Some people just need to kind of ease into it. We often talk about, telling people to ask, are you thinking about hurting yourself? And sometimes people say no, but you still have to check it out and still see, are you thinking about killing yourself? Because hurting yourself, we all know, is different than killing yourself, especially the people who use like cutting and things for coping. They might not necessarily be wanting to kill themselves, but definitely to hurt themselves. Are you thinking about taking your own life? Are you contemplating suicide? Do you have a plan to kill yourself? And that's important. I mean, some people even, they'll often talk about, oh, I wish I was dead, whatever. But some people might go so far as starting to come up with a plan. And if they have the means or the method, have they been stockpiling their medications? Do they have a gun in their home? Like, have they been thinking about what they would want to use? And most importantly, do they have a time frame in mind? That is probably the most important question when it comes to how at risk are they. Sometimes maybe the elder or person you're working with might say, I got to go to the doctor's today, and if they don't give me a prescription and I don't feel better for this, I'm just going to do it by the end of the day. And I know Carrie had mentioned in the beginning of this presentation that 10% of elders actually commit suicide on the day they see their primary care doctor, and that may be because they didn't get the answers that they were looking for. And last question, how likely are you to carry out this plan? Some people may have a plan, some means in mind, but they, I would never do it. My children need me. You have to check that out.
And one of the things, Becky, I would add is that elders are used to the pain scale that you give when you go to a doctor's office to rate your pain, 10 being high, 1 being low. One of the questions that I would ask is how likely, if they have a plan and they have access to means, how likely are they to carry it out, the plan to kill themselves? Because sometimes when you use that scale, and you can draw it on a piece of paper, you can draw it on a whiteboard or whatever you have handy, because sometimes when I'm listening to elders who may be suicidal, in my mind I'm thinking, well, they have a plan, but they don't have access to means, they don't have a time frame. So I'm thinking maybe there are 5 on the scale of likelihood to follow through. But when I ask them and I get a higher number, that's a more kind of objective measure. And if someone is definitely saying that they're suicidal and they have a plan and access to means, this is more objective information to convey to a crisis worker or someone in the hospital who's going to screen someone for potential admission. So that's just one more tool to have in your toolkit. And now I'm going to go on to talk about not so appropriate or helpful responses or questions. And again, people who are facing an elder who may be depressed, and they may be wondering if the elder is at risk for suicide, are very anxious. As Becky mentioned, this is an anxiety-provoking topic in anyone, even well-seasoned mental health professionals that have been in the field for umpteen years. Because as a lot of us know, we didn't get a lot of training of this in school. We mainly learned by the seat of our pants. Usually in your job, sometimes it happened at 4 o'clock on a Friday afternoon when your supervisor or your coworkers weren't around. You faced your first suicidal client and was like, oh my gosh, what do I do? So sometimes the things that come out of workers' mouths are not the most helpful, but let's just keep these in mind, that these are things that you shouldn't ultimately do, but if you do, make kind of a blunder, you can repair that by saying, oh, I need to rephrase that. So you're not going to kill yourself, are you? And now someone who's really anxious and that's the fear, that may be the first thing that comes out of their mouth. I know you really wouldn't do this, but you're not thinking of, or you're not going to commit suicide. Oh, things will look better in the morning after a good night's sleep. Again, if you're thinking about an elder who may have global insomnia, maybe hasn't slept for 3 nights, things aren't going to look better in the morning. In fact, they may look a heck of a lot worse. Look on the bright side. You're the happiest person I know. What could be wrong with your life? Well, if they're a person that covers up and on the outside has a facade of a happy-go-lucky person, don't assume that that's what they're really experiencing internally, because that facade could be covering up a lot of depression and pain. Don't worry about it. You're so healthy. Why would you want to take your own life? Look at poor Mrs. Henderson. She has so many more health problems than you. Lighten up. So those are things you definitely don't want to say. But if you do ask someone, are you thinking of suicide, or are you thinking of killing yourself? Don't be afraid that that may be something that, is a little abrupt or startling. Most people know that you're just asking that because you're caring enough to want to know the answer to help them out. And a lot of people think that one of the myths in suicide prevention, that if you ask someone if they're thinking about suicide, you're going to be planting a seed, that they haven't thought about that, which is totally false, because you all know that suicide is all around us in our culture. It's, in the newspaper, it's on videos, people talk about it, and I would say the majority of people have at least thought about, intellectually, hypothetically, the idea of suicide. What would happen if I wasn't around? How would people respond? So actually, if you ask someone and have a conversation about suicide with someone who may be at risk, it reduces the risk of their likely attempting suicide. So I'm going to set up the next clip, and you could see from the scene with Mo and Matt, hopefully the volume again is good, what's going on in that clip. Actually, Becky, can you set it up a little bit more?
Sure. So this is a clip of when Matt leaves again, and Mo is alone talking to this clip's a little bit longer than the other ones. It's almost 10 minutes. So Mo, is talking to Dolly's picture again. He's alone, and you can definitely see that he's contemplating what to do with the remaining 17 pills. So
okay, although the volume was a little bit better in that last clip, unfortunately Mo's voice for me was fading in and out, so I apologize for that. But I think you got a gist of what was going on, that Matt and Mo were having a conversation about his decision to take sleeping pills or to jump off purgatory chasm. When we do the live training of this, whether it's from the actual play that's presented live or whether we use the DVD in training for professionals or with elders, we ask a series of questions about the situations that you witnessed. And the question that a lot of people struggle with, and most audiences are divided, whether Mo takes the pills. Mo certainly has a lot of the risk factors, personal characteristics, life circumstances, loss, and he also has protective factors as well, the factors that might mitigate the risk factors. He has obviously caring people in his life, Sadie the caring neighbor, Matt his nephew. He has social support. And he and Matt are engaged in a conversation, a pretty lengthy conversation that they say is going to continue the next day, which, as we know, decreases risk of people actually following through on suicide. Becky?
Okay. So what about most situations makes him more or less likely to kill himself? Now, Kerry just said he had some protective factors and he had some risk factors, but here we just go into a little more detail. So what would make him more likely to kill himself? Well, statistics say he's 85, he's Caucasian, and he's a widow, so that automatically increases his risk. Mo never had any children. Granted, he's got Matt, which probably is like a son to him, but still no children. It seems like he lost interest in his life. You know, he's not going on those bus trips with Sadie or going out much, just to the pharmacy, the store, get his sandwich, and that's about it. Recurrent thoughts of suicide, I mean, he definitely talked about it a couple times with Matt, a couple different ways, pills, jumping off purgatory chasm. Giving away possessions, the lace that Dolly had made, you know, he gave it to Sadie, no problems, didn't want it back. Possible sleep problems, we really can't confirm that, but he did tell his doctor he was having sleep problems to get the prescription. Not sticking to his diet, I don't know if you guys really picked up on this, but he's been eating like sandwiches and pie, and that's about it. He's obviously still grieving the loss of his wife, constantly talking to her picture and talking to her. It doesn't really go into detail of how many years she's been gone, but still definitely that's on the, you know, he's still grieving that. Does not appear to be very religious or spiritual, doesn't really talk about God or the afterlife or anything. Previous plans of suicide, like I mentioned, purgatory chasm. He's retired, and he appears to be depressed, just given the other symptoms, the possible not sleeping, not eating, you know, lost interest in things, isolation.
And I just mentioned, Becky, that one of the things in his talking to Dolly and having a plan, in one of the earlier clips, and I don't know if people could hear it, he was talking about reuniting with Dolly. You know, a lot of people who have that belief may be more likely to end their lives if they think in the afterlife they're going to, you know, meet loved ones and things are going to all kind of work out.
So what makes him less likely to actually go through with suicide? We mentioned this kind of before too, but he's definitely less likely because he's got caring people around him that are concerned. Matt really did sit with him for a while and talk about it. Though you could tell he was kind of uncomfortable about it, he definitely let Mo talk about it. He's got connection to the community through the diner, like I said before. He's relatively healthy. I mean, he took a tumble and he got right back up. So I'm wondering if, you know, he did hurt himself. It sounds like he would be more at risk because he had talked about his friend Johnny, who's in a rehab or nursing home, and how, you know, he doesn't want to end up like him. He shares his feelings about death with others, definitely. Does not appear to abuse any substances. And so he won't get that like liquid courage, if you will, from, you know, people who do use. They're more likely to at least make attempts because their inhibitions are down. And no prior history that we know of depression or past suicide attempts or suicides within the family.
Okay, so we are actually going to talk about the neighbor, Sadie. Does she have any reason to suspect what he's planning? And if you go over the risk factors in your mind, you may see a couple that stand out. She, in the clips, has been trying to get him to go out, to go trips. She goes on a lot of senior trips. They go to Atlantic City. She has actually asked him, and I don't know if you could hear this in the clip rather, with her, that she had asked to come over and watch old movies and cook dinner for him, and he kind of, just brushes her off. Mo is giving away prized possessions, at least the lace that Dolly made that Psy.D takes home and has a stain in to clean. He tells her that he doesn't want it back. But yet in the conversation they talk about how Dolly loved making those, how she really prided herself in those and having, nice things in her home, and he's giving it away. He's not following his diet. I believe Mo had a heart attack in the past, and he's on a special diet, low sodium, and as Becky said, he's having ham and cheese sandwiches and is having a lot of sugar and desserts. And he did visit Purgatory Chasm about a month ago. He had Matt drive him up there to visit. He didn't get out of the car, but sometimes people who actually go and look at various sites that they are contemplating for suicide, that can increase the risk. As we know, a lot of people jump from bridges for suicide, and the Golden Gate Bridge in San Francisco is one of the most common places that people go to commit suicide. And sometimes people will do rehearsals or dry runs where they will, park in the visitors parking by the bridge and walk up and down the bridge and just look over the railing and see how high it is and kind of practice for the time they do come back and actually jump. Becky?
Okay. What about Mo's doctor? Is there anything that she or he could have done? That's where obviously he got the prescription for the sleeping pills from. And, she or he could have asked about his mood, his depression, if he was having any thoughts about death. I just learned the other day that during an appointment, which is, maybe 15 minutes long at most, doctors only spend 2 minutes talking about things as depression or anything. So it doesn't really give a lot of time to really go into detail about it. And, Mo, who knows, he probably didn't want to disclose it if he got the medication specifically for this reason.
And a lot of times with older Americans, when they go in for doctor's appointments, they may be reluctant to talk about emotional issues, and they may be more likely to talk about emotional and mental health issues through physical symptoms, talking about headaches or stomach aches or increase in arthritis pain. And if the PCP does not ask more about the pain, like, could it be related to the loss of your wife or the fact that you're retiring or the fact that you've moved from your own home to an assisted living, they're not going to get the information necessarily on their own because elders don't necessarily volunteer it. And if the average managed care appointment, the limit that managed care sets, is 15 minutes, if an elder really does have issues with blood pressure and vision and legitimate other health things, they're not going to be able to get to the mental health issues as well. And a lot of suggestions that we make to people who work with elders or family members, that a lot of time if you suspect that your loved one may be at risk or may be contemplating suicide, that you either talk to them about going into the PCP with them or have a conversation with the PCP beforehand. And frankly, in defense of PCPs, they don't get a lot of training in depression screens and suicide prevention and not even prescribing medications. PCPs that are prescribing more antidepressants or anti-anxieties, that's been a more recent phenomenon that not a lot of them have training in, but more and more people are expecting it. Another issue I just wanted to mention with healthcare practitioners, at my own actual healthcare practitioner, about a year ago I saw a note on the waiting room saying, please limit your concerns that you discuss with your healthcare practitioner to 3, which really mortified me. Kind of like the limit your transitions at the bank to 3. So if you're reluctant to talk about any sort of mental health depression issue because of stigma, and you also have a number of other medical concerns to talk about, you're not going to be able to get all your concerns, addressed in the 15-minute conversation.
Can I just add also, Carrie, that
Mm-hmm.
in the beginning, I think it was the first slide, Mo had mentioned he's tired. So he could have said that also to his primary care doctor about how he was being tired. And what do we know about being tired? You're not getting enough sleep. So what's the magic pill for that? Obviously maybe that's what the doctor thought, but really maybe Mo was starting to talk about tired about life. But, so it could have been like that.
Exactly. So another question we often ask is, does the conversation that Mo had with Matt, the nephew, increase or decrease the likelihood that Mo will take the pills? A frequent myth that people often believe is that, we're skipping, sorry about that, is that talking about suicide increases the likelihood of someone completing it. Now, we know that that's not true, that actually talking about suicide and plans and feeling decreases risk. Anytime you can have an honest conversation about feelings and thoughts surrounding suicide where you make them feel understood, cared for, and trusted can decrease risk. And if they know that you're willing to have that very difficult conversation, to ask the S word, the suicide word, as we say, they know that you're someone that they can trust, and that you and them will collaborate to find them solutions to solve their problems, to look forward more to life-sustaining and enjoyable events. So if they can talk to you about such an important topic, hopefully they're going to stick around and work out the problem by talking to a religious advisor or spiritual advisor or a counselor or their family members or a lot of the other options that people can talk about, solving problems rather than using suicide as a way to end their pain. Because one of the things we know about people who are suicidal, either people who are suicidal and who have attempted but not completed suicide, or those who are chronically suicidal, is that they're in intense emotional pain. And really, in thinking about suicide, it's not about ending their life. It's about wanting to end the pain. They're looking for any solution that can help end their suffering. And as Becky mentioned earlier, when people are depressed, their ability to generate solutions and solve problems is decreased because they go through kind of a cognitive constriction where they can't think about as broadly of, options or be able to brainstorm about solutions as they may have in the past. So sometimes asking about, have you ever felt this way before in the past? What have you done? How have you solved that problem? Because you're obviously here. How did you negotiate that? And mentioning to them that there have been problems like this in the past that they have solved can give them hope that they can now solve this problem currently. Okay.
Was Matt right to throw the pills away, and what kind of effect do you think it has? So restricting the means can be an effective way of stopping impulsive suicidal behaviors. But I feel like Mo is kind of on the fence of what mean he wants to do it, if he's going to do it. I mean, he definitely has these ideas of taking the sleeping pills, but then he also has the idea, and he even asks Matt, will you push me off of the cliff at Purgatory Chasm? He's a little bit ambivalent of ways that he could go. But definitely taking things away, obviously, people can't be impulsive and do it. It can also exacerbate the elder's feelings of lack of control, thus increasing motivation to succeed. I know Mo has mentioned in the last clip especially that, he wants to decide when he goes out. And I think he wants to decide before he gets sick. He probably saw Dolly suffer for way too long and doesn't want to be in the same boat. He sees his friend who just went into the rehab or nursing home. He just doesn't want to get there. So, if you take away the way that they can do it, they're more likely, they want to be the ones in control if they're really feeling that way. It's important to gain consent so they feel that they are part of making the choice to remove the means. You can't just take them on, flushing them, end of story. Just have like a conversation like, wouldn't it make sense if we threw these away because we don't, just kind of make it so that the person is also in agreement to what you're doing and you're not just doing it without their consent. It makes it probably a little more meaningful and a little more what's the word I'm looking for, effective, because they are part of that decision. And if the elder continues to have access to the means, has a plan and intent, then obviously, like I said before, their risk is pretty imminent. And it would be probably wise to get them to some help, like the emergency room, call the crisis team, call another family member, come up with a plan. So.
And one thing, Becky, that I would say with that is, in addition to what you were saying and making the elder feel like that you're on their team, that you're there to help them, even if you think they do need to, go to crisis or go to the emergency room, I would tell them, look, I think that you're really at risk. I fear for your safety, so I think we need to call your son or daughter. I think we need to go call crisis or contact crisis, but would you like me to do it, or would you like to do it? And sometimes when you lay out the plan and you give them the chance, and if they want to be autonomous and make one of the phone calls, I think that can make them more in control and can also let them know that you're working together and that you have their best interest at heart, and you won't leave them alone. You will walk them through this process to get them whatever level of help that they need in order to, have another day to consider other options about sustaining life and solving problems rather than choosing suicide. As Becky had mentioned earlier on, everyone has the right to think about and to possibly take their own life, but usually it's an option that they choose only because everything else feels so dire, they feel so desperate that they don't know any other way. So acknowledging that, yes, that is their choice, but we certainly don't want you to make that when you're so depressed or so incapable of seeing, the future, that you choose that when things may have gotten better with resources and help. So the next question is, Matt says that he will be there in the end. Would it be right for Matt to sit back, have a drink with Mo if he knew he was planning on killing himself? Now we saw that Matt did flush the pills, but what else do you think that Matt could have done? One of the things that we know statistically is most people who kill themselves are depressed. And depending on, what literature you read, between 90 to 95% of people are depressed who either attempt suicide or actually complete suicide. Again, the psychological pain that we mentioned before, seeing no options, no other way out. If you look at the statistics, between 90 and 95% of those are depressed, there is between 10 to 5% of people who may be desperate, meaning they may not be depressed, but they may find that they're in a situation that they can't escape. They're desperate because they're going to be arrested or they're going to be incarcerated, so they take matters into their hand by jumping off a bridge. There was a case in the 90s of, although these weren't elderly people, a man who had murdered his pregnant wife because he was having an affair. And when he found out, he said that they were on the way home from Lamaze class and that man had both shot he and his wife, and it was all a ruse, a lie to cover the fact that he had shot her. Charles Stewart was the name of the man. And when he found out that the police were closing in, they were about to arrest him, he jumped off the Tobin Bridge. As far as we know, he wasn't depressed, but he was desperate. He wanted to escape a situation where he felt he was going to be caught, he was going to be accused, so the shame and embarrassment and stigma about that, and he probably was going to be incarcerated for a long time. Talking about other options, to reduce risks and give them hope and other alternatives can certainly help kind of open their minds that may be constricted through depressions and help them see that there are other options. One of the other myths that we often encounter when we do suicide prevention training is that, you can't talk someone out of it. If they're talking about suicide, it's too late. But we know that that's not true. Again, that if talking about suicide, it's usually about the intense pain they're feeling. And they, again, want to find, some other options besides ending their lives. Becky, I'm going to turn it over to you.
Okay. So should Matt have taken the steps to convince Mo not to kill himself? And if so, what kind of steps should he have taken? And trying to talk to someone about someone out of suicide is not the best approach. You know, like I had mentioned before, lay it on the table. It's an option. It may not be the option that we automatically go to, but, you know, this is what somebody's thinking about. So, you know, validate that, you know, wow, your situation is so bad, you know, it's a shame that that's the, you know, the option that you're thinking of right now, and that's the best solution. So, you know, just validate that. Just remember also, as rare as it is, not every suicide is preventable. But I find in, you know, my professional job is that, you know, it's the people that we never talk to, the people that never talk about it, and the people that are never assessed by the crisis team. Those are the ones that you hear about, and you're like, wow, who would have known? Because they aren't the ones that mention it. So suicide, you know, sometimes is not preventable because, you know, sometimes people just don't give you clues. But in Mo's case, clearly he's giving clues. He wants to talk about it. He's ambivalent. He you know, needs reasons. So, and there's no right or wrong strategy or technique. You're not going to plant seeds. You're not going to, you know, say something where somebody's just going to kill themselves. Like, but there are appropriate ways to approach the subject. You know, definitely validation, and just having people know that they're cared about and that you really are there to help them.
And I would say one more thing about that, Becky, of you know, to not only validate that people may be in pain and contemplating suicide, but actually to normalize, and it seems a little counterintuitive, but someone who may be going through intense situational pain, like Mo, you know, who has lost the love of his life, the woman he planned to spend the rest of his life with, and may not be bouncing back to that and adapting to change, you know, may be really feeling intense pain. And to say that it may be, you know, typical that you might be wondering if you can go on without Dolly, and maybe thinking about other means. And certainly if he believes that he's going to be reunified with Dolly, that might be a logical thought that he would have. And again, we're not encouraging people to think about suicide because we know they're already thinking about it anyway. We're not encouraging them to do it, but just to say that yes, people who are often depressed may have these thoughts, but there are often other ways to deal with those situations rather than, you know, taking your own life. And again, on the no right or wrong strategy, when we mentioned the helpful questions before, people tend to get anxious and panic and think, I don't want to choke on my words, I don't want to say the wrong thing. But again, if your intention is to try to understand the elder you're talking with and try to help them see other life-sustaining options for themselves, that intention will carry. And even if your words are not the most precise, you can make amends, you can apologize, you can make repairs for that. But if your intention is true, that you want to help them, that's the thing that is going to most convey to them, and that's what they're going to be stuck with, left with, not that you kind of jumbled your words. And I've often said, you know, to folks that I'm assessing or someone who I'm meeting who may be suicidal, you know, this is a very scary topic. And I'm nervous because I don't want to be the only one that you've talked to about this. I think we need to kind of broaden the circle and get your family in and get crisis in if that's necessary. So you have other people to talk to. You have other supports. So usually that's comforting to people, and they feel taken care of and taken seriously as well.
And the last question that we usually ask after showing the movie or the play is it Matt's role to intervene, or should the choice to die be Mo's? Now, this is a very controversial question, and your answer will often be influenced by your views of the following questions. Do you think suicide is morally wrong? Does a person have the right to take their own life? And does society have the right to prevent a loss of life by suicide? So this is really right to die versus beneficence. I don't know if you have more to add about that, Kerry.
Well, I think that it's a very, touchy topic, and depending on people's religious and spiritual beliefs, I mean, certainly in traditional Catholicism, as you mentioned earlier, it used to be believed that if someone committed suicide, that they were going to hell. So a lot of people would not even contemplate suicide if that kind of religious belief was so morally ingrained. And then in several states, Oregon is one of them, there is physician-assisted suicide, and it's usually for people who are facing terminal illness of which treatment is no longer helpful, that a physician will be able to end their lives through injecting morphine and other means. Some people are morally opposed to that. And in this particular training, we're not taking a stance on what's right or wrong. That's for people individually to figure out. But from our position, most of the people, again, between 90 and 95% of people who contemplate suicide are depressed. And that's a medical condition that must be treated. And if the person, after the depression is adequately treated, still decides that depression is an option, then that is there to choose. So we're not weighing in on that. We're just weighing in that, depression is something that often, very often, overshadows people's decision-making ability, and that must be treated before the person can go on further to make appropriate decisions. I'm going to go on to the last couple of slides on the resources that you can find help. Certainly most folks know about the Samaritans, that you can call in anytime, day or night. If someone you know is feeling at risk or suicidal, you can also call as a family member or provider if you have questions. The Yellow Pages can provide information about services in your area, mental health services that can be helpful, crisis services, or local hospitals. 1-800-AGE-INFO or www.800ageinfo.com can provide various information about services in your area, and that is the one actually that if you enter your zip code, they can connect you with local services. National Suicide Prevention Lifeline, 1-800-273-TALK or 8255 is another hotline that can provide you with information. And SAMHSA, which is the federal government Substance Abuse and Mental Health Service Association at www.samhsa.gov, can also provide a mental health locator by your zip code. For folks that want more information on who do screening, more clinicians, the geriatric screening tools, and actually these can be applied by anyone. They don't need to be done by clinicians. They can be used in social service centers, primary care. The PHQ are a couple of questions, and if the person answers affirmatively about depression and suicide, then you administer a 2-question scale, which is the PHQ-9. And if you don't know these tools, they're available online. You just Google them, and you can download and print. Geriatric Depression Scale specifically is geared toward elder depression and looks at depression and warning signs as well as risk for suicide. SAFE-T, which is a suicide assessment 5-step evaluation and triage scale. Again, most of these resources are available online, as well as the resources for living, it should say inventory, should be a Y at the end of that. And that's just a way to generate, with a person who may be at risk, reasons for continuing to live, whether they're religious, whether they have grandchildren, whether they have family members that they're looking forward to seeing. And again, a lot of elders may be isolated and cut off from the resources. So if you can reconnect people with the supports, that can be doing them a great service. And lastly, in conclusion, we all belong to the community and to the larger human family. To engage with an elder, to know the warning signs, to ask the ask question, to be able to take action, to ask them help, it is a step in preventing suicide, because no matter the age of the person, suicide is a tragedy, and it takes a village of trained people to make a difference in elders' lives. For our contact information, if you have more questions, if you would like to purchase the video Talking with Dolores, on the screen you will see Becky's contact information. The DVD is $50. If you would like to purchase that, you can contact Becky. Right now we're just taking checks for that, but we will get that out to you. And if you'd like to talk to us more about any of the things we presented in this webinar or suggestions for how to use the DVD as a tool in your community, or if you would even like to have a live performance of the play, we would be glad to give you that information. And I would just like to say thank you for participating, and we have about 3 more minutes. If you have any questions, you can log on and we'll try to answer them.
Yeah, just to echo Carrie's last statement, if you do have any questions, we have a bit of time, so please use the chat function and type in any questions that you may have.
I actually see a comment actually that Pete made about the Oregon law. And Pete, I do believe you're correct, that the physician does not, him or herself, administer to the patient that may be terminally ill and wanting to commit suicide. Usually it is the medication is given to the patient or the family member. So thank you for clarifying that. I apologize for misspeaking.
Okay, well, it does not look like we have any additional questions, so I just want to take a moment and thank both Dr. Morrison and Rebecca Kessler. As well, I want to thank all of you for participating this morning. I don't know if I mentioned it, but I will be sending up a follow-up email to all the participants in today's webinar. I'll also be posting this webinar as a podcast on our website, and you'll get the link for that in the follow-up email. In addition, be on the lookout for emails about upcoming webinars and workshops being sponsored by DPH, Department of Public Health. After you log off today, please take a few moments to complete the webinar's evaluation. I hope that all of you that are participating have gained a little bit more knowledge about elder mental health, depression, suicide, as well as some of the resources available to combat this very important issue. So if there are no more questions, again, I want to thank Dr. Morrison and Rebecca Kessler, and thank you all for participating. Have a wonderful day.
Thank you. Please stand by.